Cardiovascular Institutes. They are very famous in the United States and Harrisburg, and he's the chairman of C3. I know him since almost 10 years, and he's always progressing with now he's having Interventional Academy, and he's very much interested in education, and he's supporting very much the fellows. We thank him for always taking our fellows and our young cardiologists in Orlando. And now he is now with us since we couldn't go to Orlando this year, but he was kind enough to share with us in this interesting webinar. Raj, please.
Thank you very much, Ahmed, for that very kind introduction. Secondly, thank you very much to all the faculty who has taken their valuable time to be with us today, including all the speakers from Egypt, especially given that it's a late time in Egypt, also late time in Europe, and we really are grateful for your contribution. With this, I think we're not filling the gap in the knowledge that exists across the world in absence of our live meeting in Orlando. And with God's graces, hopefully we will see everybody in Orlando again together in June 2021. So let's talk briefly about PCI optimization. These are my disclosures related to this presentation. So I truly believe that there are few remaining areas in PCI that is going to reduce the need for future CABG as well as the need for future cardiovascular events in future. And one of the key factor besides optimization of medical therapy and risk modification is PCI optimization. The second key area is a complete revascularization, and third key area is risk factor modification. So I'm going to address the first area today of PCI optimization. I'm going to show you an example of why I believe very strongly that PCI optimization really can add substantial value to your daily clinical practice. So this is a 82-year-old gentleman. He's a retired orofacial-maxillary surgeon. He has a history of diabetes, hypertension, and hyperlipidemia. He was admitted to a outlying facility, which is about an hour out of here. After being admitted for unstable angina, he underwent cardiac catheterization over there, which demonstrated that his left coronary system only had mild disease. And however, the right coronary artery had a very complex, angulated, heavily calcified ostial and proximal RCA disease. So he was then referred to me for intervention. You can see this is the angiogram. And clearly there is a whiff of dye going through this massive chunk of calcium. This is in the proximal right coronary artery. And there's obviously no mystery in this case. So what I did was I attempted to cross this lesion with an intravascular ultrasound, and you can see that the IVUS catheter absolutely didn't cross. We can see a very thick rim of calcium with the in the proximal right. So we went straight to a rotational atherectomy, and the rotational atherectomy was done with a 1.25 millimeter rotational atherectomy bar. After rotational atherectomy, I was able to pass the IVUS catheter into the lesion. And you can see that there's been a couple modest cuts with the rotoblader. And this IVUS, I don't have a full IVUS run, but it was felt that the lesion was modified enough that we should be able to dilate this stenosis and be stented. So which is what we did. We performed dilatation, and we implanted 2 everolimus eluding stents in this right coronary artery. And you can see that the result looks fantastic. We checked everything with IVUS, and there was a proper expansion of this stents, and the patient was then discharged the very next day. I get a call about a week later, 2 weeks later, from the same outlying facility where this physician was admitted the first time, and said, you know, such and such doctor is admitted again with unstable angina. He's been very compliant with his dual antiplatelet therapy, and he did not have any cardiac enzymes, and he only had 1 or 2 episodes of angina. So they decided to perform a nuclear stress test on this patient to see if he had just an atypical symptoms. However, he was indeed found to have large inferior wall ischemia on his nuclear stress test. So they called me and sent this physician back to my hospital for another cardiac cath, because they were not comfortable discharging this patient with such a large degree of angina, and they thought that we should do a repeat angiogram. So this is 2 weeks later, in a previously treated calcified right with 2 brand new everolimus eluding stents. And now we see a 70% eccentric proximal RCS stenosis in a DAPT compliant patients. So open it up for a discussion for a couple minutes to the panel to see if anybody wants to take a stab at this, what they would do with this, whether they would say this is an underexpanded calcium, thrombus, what it is, and how should we deal with that?
Peter?
Yeah, a great case, Raj. Gee, I don't know. I think this would be very late to have calcium protrusion. You know, sometimes you see this debris, especially in the right. But I think your initial angio was so perfect, but you sort of gave away the answer. You know, OCT would be really interesting in this case. Whether it's a stent fracture, you didn't tell us how aggressively you dilated with a superimposed thrombus. I'd be eager to see it, but I think OCT is the right way to go about it. You need to know what is functionally happening there.
Yeah. So, well, given that he was already admitted with a acute coronary syndrome and unstable angina, you know, we didn't thought that, you know, we would do physiology, given that this was a clear-cut something that we needed to address, you know. So we just went straight to an OCT examination here. And this is the OCT run. You can see that there. This is the OCT catheter. And this is the angio and the OCT at the same time. And let's see if we can play the OCT run now. Okay, I am not able to play the OCT run. However, if you look here, right here where my mouse cursor is, the proximal everolimus eluding stent is completely disrupted and is broken into 2 pieces. You have a proximal RCA piece. Then there is a huge gap here in this right coronary. And then there is a continuation of the same stent where there was clearly only 1 stent implanted there. And then the overlap of the stent is much more distal to this area. So this within 15,
are you sure you don't have a 4 millimeter long everolimus stent that you misplaced there?
Yeah, you know, so that's great. So no, this is so this is a you know, there is only 1 reported case of early stent fracture in the literature within 7 days, and then there has been several reported cases after months of implanting stents, but this would be a pretty early stent fracture. So that's what was seen on the OCT. I don't think that any other technology could show you this. You know, I think that You could do an IVUS. I've been doing IVUS for 25 years, and I don't think I can tell on IVUS if there's a stent fracture, but on OCT, we certainly can.
IVUS after first session?
Yes, we did do the IVUS, you know, so we tried IVUS first, IVUS failed. So we did ROTA, then we put the stents in, then we did IVUS, proper expansion, everything looked great. So the risk factors for coronary stent fractures are heavy calcification, angulated coronary segments, a right coronary artery. That's an important risk factor for stent fractures that's reported in the highest number, and overlapping stents. So now you can see another 4 millimeter everolimus eluting stent was implanted now to treat this stent fracture. And this is a repeat OCT run to evaluate how it looks. And now you can see that the stent fracture is taken care of. Let me see if I can play this run. I don't know why it's not playing. But regardless, you can see very nicely in the longitudinal view that there was an 118% and almost 80% plus expansion of these stents. There is no red in that white rendering of the stent, which shows that the stent is properly opposed and well expanded. So in conclusion, coronary stent fracture is a very underreported and underdiagnosed phenomena. With OCT, definitive diagnosis can be made in absence of stent strut, which is the pathognomonic feature of a stent fracture. In the autopsy study, one of the autopsy study that I'm quoting here had 26% incidence of coronary stent fracture. However, pathological sequelae of stent fracture was only seen when the stent fracture was grade 5 or greater, such as in this particular case. All bare metal and drug-eluting stent fracture has been reported. However, sirolimus stents had the highest reported incidence. Sirolimus eluting stent, which is Cypher, not available in the US now. I'm not sure whether it's available in Egypt. Other factors for coronary stent fractures are stent overexpansion, overlapping stents, long mishandling of the stent, conformability issues such as rigid straightening increases the chances of a stent fracture, and RCA and SVG lesions have high incidence. So with that, I will conclude. I hope this was an illustration of how PCI optimization and the current new high definition technology in imaging can substantially add to your PCI practice in 2020.
Thank you, Raj, for the excellent case and demonstration. Let me ask, what other situations where the OCT practically was very useful in telling the answer of the mystery, as you named your lecture?
Yeah, so that's a great question. So in our lab here, we have been using OCT since OCT was first released via St. Jude Company, which was then purchased by Abbott Vascular. So we have a long OCT experience in our lab. Our OCT penetration has gone up and down over the period of years, but I think average OCT penetration in our lab is about 50 to 55% of patients. Our most common OCT uses are instant restenosis, calcified lesion. So for instant restenosis, we are usually looking for stent under expansion as a, or etiology of instant restenosis. We are looking for new atherosclerosis formation with OCT, which is very, very easy to tell in comparison to any other imaging technology such as IVUS. In calcification, we do it after the rotablator because then it tells us if we need to do more work with the rotational atherectomy. If the calcium plate is still thicker than 500 microns, or if there's not enough fractures in the calcium plate, then we would do either a bigger burr or go with the same device if we were using orbital atherectomy and do more runs. So those are two common. Third, most common reason why we do OCT in our lab is acute coronary syndrome, where we are looking for vulnerable plaques, and we are looking for ruptured plaques in the patients with ACS to make sure that we provide a good scaffolding coverage of these areas, because we believe that, you know, those large plaque ruptures should be covered to make sure that we prevent repeated events on those patients. So I think those would be our most commonest imaging cases where we would consider OCT imaging.
So Dr. Ammar Kamal is with us now. Do you like to comment? Unmute yourself. Unmute, ya Ammar.
Yeah. Yeah. Hello. Hello, everybody. You hear me?
Yes, we can hear you fine.
Yeah. How are you, Raj? It's
fine.
a very nice presentation.
Yeah.
It's very nice presentation, and it's usually amidst the entity within the intervention, which is the coronary stent fracture, because many people miss this in the evaluation, especially of patients with acute coronary syndrome after PCI, especially in the grafts. Sometimes it occurs in the native vessels if you use aggressive post dilation in the first procedure. But I agree with you 100% that it is under-recognized, and we have to usually use either imaging during the PCI to verify that there is no coronary stent fracture, especially if you are dealing with excessive calcification or if you use excessive post dilation. For the underreporting is also, I agree with you, because it's underreported because of course it's under recognized. But I agree that it's a very nice case, and the OCT solves this rather than the IVUS, of course.
Is it related also to the longitudinal distortion of the stents? Is it also one of the things that you can diagnose with OCT, or it makes any kind?
Sure. That is of course related to the distortion, the longitudinal distortion, but actually the fracture is related more to the radial force of the stent, radial force, not to the longitudinal shear, but the radial force applied to the stent, and of course how you manipulate the predilation before putting a stent, of heavy calcification in the native vessel or in the angulation vessel, or at sometimes at the stitcher or the stitch type lesions with the lima and ElNady. This is usually, or with acute angulation of the vessel, this is usual places of stent fracture, and you have to search for it, but it's more common with the radial distension more than with the longitudinal shear.
So before we move to cases, Sandeep or Peter, do you like to comment?
Yeah, I think, you know, Raj, it's a great case, and I'm kind of scratching my head as to how I might have avoided that, because you did all the right things. You debulked it, you got a beautiful angiographic result, and you followed up with IVUS. So, you know, what's the message in terms of, you know, an avoidance strategy if you're, you know, encounter the same type of lesion? Do you think that, do you think it has to do with sort of differential force on the stent? The comment was made about radial force, differential force on the stent because of the calcium or the amount of debulking, or do you think it's just the location and the flex?
I think that's a great question, Sandeep. You know, I think that in this particular case, you know, I was very, very aggressive in dilating the proximal stent to the right. You know, so I think I may have dilated, I don't exactly remember, but probably at 22, 23 atmospheres with a post-dilatation balloon. And that may have been, you know, too much with an interaction between this new generation relatively thin strut stents, you know. So if we were to use something like a Cypher or a Crown Flex stent in the old days, you know, with that degree of pressure, you know, the stent is not going anywhere. But now with the new generation devices like Onyx and the Zions and the Synergies, these are thin struts, and it's not able to take that much beating, I think. So what probably, you know, we should have done the first time around is that after we had implanted the stent, we should have done an OCT run and then decided after that whether we needed to do more aggressive post-dilatation. And then that could have been potentially been a good approach to avoid a stent fracture. But I think that, the issue really is that there is a ton of coronary stent fracture cases out there. And most of these cases are being ballooned and stented without proper diagnosis, because people will see a stenosis like this and they'll say, okay, well, it may be a plaque protrusion, it may be some calcium, maybe something, but 90% of people would say, okay, well, just balloon and stent it, and that would be the end of it. And which I think ultimately what we may be the treatment anyway, but I think is the issue is, are we recognizing these cases?
Dr. Raj Al-Hadidi from Egypt, how are you? It's excellent presentation as usual. Do you hear me? Do you hear me, Dr. Raj?
Yes, I hear great.
Okay. You have a case with a stent fracture. So every case you balloon it. Every case you stent it, or you can leave it after balloon? If you have a
I think that, that's going to be your judgment call. But, most of the time, we personally would not have recognized a stent fracture unless the patient had come to us for some kind of a symptoms and there was a reason for us to look. So if the patient had come for symptoms and they had this type of clinical picture, which usually is what the clinical picture is, then we almost always would put a second stent in just to make it certain that the patient is not going to have to come back. And that's really, but if we find to do a balloon and see how this patient does, or maybe consider doing a drug-eluting balloon, and that would be another reasonable choice as well. But I would say, in our lab, we would almost universally would stent it because we would have recognized it only in context of symptoms. We don't do asymptomatic follow-up angiograms.
Thank you.
So with that, I think we will move. So I'd like to tell you that Dina told us that already there is 4,000 doctors who are already watching us through the Facebook and through the different internet. And by Raj, it's almost 200 in the States also. So we had been watching. Thank you for
2,000, yeah, doctor. 2,000. 2,000 is Dr. Raj, yes.
2,000 by Dr. Raj. And what is the number by you? 2 or 4?
4,000. Just a minute. Now is 4,061.
Okay.
Wow, that's great, Ahmed. Congratulations.
Yeah, it's congratulations to everybody, and it was a great session. And now we are moving to the cases. I know that Raj and Peter, although they are chair